Evening, everyone, and welcome. My name is Sam Patterson, and I'm the operations director here at Iowa Veterinary Specialties here in Des Moines, Iowa. We're thrilled to partner with Serial Repair tonight to host a continuing education event. We're also glad that you can join us for this highly important practical topic in veterinary ophthalmology. At Iowa Veterinary Specialties, we are a 24-hour emergency pet hospital. And part of our mission is advancing veterinary education and collaboration. Events like these, like the one tonight, is bringing cutting edge technology and science and real world strategies directly to veterinarians who make a difference every day. We host these every month. To learn more, you can go to our website at iowaveterinary.specialties.com, IVSDSM.com. Tonight's presenter is someone who embodies the commitment to excellence in education. Dr. Melissa Kubaiwill, DVM, is a board-certified veterinary ophthalmologist and highly respected educator and clinician at Iowa State University. She brings deep experience in ocular surface disease, coronary infections, and emerging use of blood-derived therapies in eye care. Before we begin, a few housekeeping notes. This is a 1-hour CE session for the Iowa DVMs. Please stay for the full presentation to receive your CE certificates, which we will mail to you by next week, end of next week. You're welcome to use the questions, submitting questions throughout the presentation in the Q&A chat box, and that will be up on the upper left-hand side for me. I'm not sure if that's where that will be for you, but I'm pretty sure that's where it's at. And then at the end, we will have a Q&A session with Dr. Kubaiwill. A recording of this will be made available after through Serial Repair for anybody who's registered. And before we dive into the CE event tonight, I'd like to introduce Serial Repair, a company that's advancing ocular care in veterinary medicine and a co-sponsor for this event.
Hey everyone, this is Troy Openshaw, and I'm joined with Aaron Bach, and thanks for joining the call tonight. Aaron and I have been in the biologics world for several years, well, many years, dealing with stem cells, PRP, and other regenerative products in both the animal health, and we've also done the human medicine side. And Serial Repair really started a few years ago with the idea from actually one of your colleagues from Iowa, Dr. Nathan Hine, who had this idea to eliminate the need for blood draw and all the processing involved with making eye serum in clinic, which we know can be extensive and can last quite a while. And we love the concept, we love the idea, and then we decided to launch Serial Repair. And together with Dr. Hine, it's just been an amazing journey, just a rocket ship. So with that, I'll hand it over to Aaron.
Thank you, Troy. Yeah, as Troy said, we've both been in the field of biologics for a while, and I personally have about 15 years of experience in animal health and have enjoyed every bit of it. So yeah, when Dr. Hine called several years ago, talking about making a product that we could give vets a faster and more effective way to deal with ocular cases, we both jumped in with both feet. So yeah, so what Serolube is a bovine-derived or bovine blood-derived frozen eye serum. It eliminates the need for in-clinic preparation, no blood draws, no staff processing, and no contamination risk. And so why that matters is we can take a 45-minute appointment down to about 10 minutes, which dramatically improves the pet experience and improves the experience of the pet parent. So, oh yeah, I wanted to also mention we've got Serolube growth factor coming soon, which is a growth factor enhanced product. It's an absolute game changer. Think traditional eye serum, only on steroids. So stay tuned for that. Oh yeah, last thing, we're running a promo for everyone registered for this course. It's free 2-day shipping, and I will send everyone an email tonight with a link to that if you want to take advantage of that. So yeah, I would like to, I guess, introduce Dr. Kubaiwill, and I hope you guys all find that her information and research is interesting and informative as we have, and so I'm going to hand it over to Dr. Kubaiwill.
All right. Thank you so much, Aaron. I'm going to get my PowerPoint shared with you all, and just bear with me for a second. Okay, here we go. All right, let me switch this up. All right, hopefully you all can see that. So I'm thrilled to be here to chat about demystifying corneal ulcers, specifically infected ulcers. So identifying infections and leveraging blood products to improve outcomes. A little bit of backstory: I'm kind of obsessed with the cornea, and so this is kind of we'll talk about infected corneal ulcers. We'll go through a whole bit of research that we did. One published research paper and another on the verge of getting submitted and hopefully published in the near future. So this is a bit of a passion project because this is what we deal with every day in the ophthalmic world. So I hope this is informative and helpful, and that's the whole point. So let's delve into infectious keratitis. So bacterial keratitis, as we know, leads to significant discomfort and vision loss without appropriate treatment. And as we can see in this image, a lot of our patients, if you can see my pointer here, mouse, come in looking like this. So we've got this really nasty infected ulcer, loss of corneal thickness. You can see the curvature of the cornea is abnormal. So anytime we see that, we see stromal loss. So instead of skin peeled off a grape, there's a cavitation, and then we've got this, sort of whitish appearance to the cornea, and that's a mixture of infiltrate and malacia or melting, and we'll talk about that. The body's natural response is to bring in blood vessels, which is a natural supply of blood products, but we need to get the patient there in order to get those vessels to grow in and help heal this infected ulcer. So we have to help it out because it takes a while for those blood vessels to get in there. So most common bacterial species that we see gram-positive are gram-positive species, which are Staphylococcus and Streptococcus. Again, cornea is modified skin, so those are the same things that we see on skin. Again, that's something I try to keep it simple. Our most common gram-negative bacteria is Pseudomonas aeruginosa that we see in our canine population in this area, especially in most areas in general, but especially in Iowa, in the Midwest. And so when we're talking about infected corneal ulcers, we always, you may hear that term malacic cornea. And what does that mean? Well, it's an appearance where the cornea just looks kind of like it's melting. It's kind of this snot-like appearance that when you try to, rinse it away, it just doesn't remove or go away like mucus would. And if you numb up the cornea and you were put a cotton tip applicator on there, it wouldn't remove. It sort of snaps back. And that's basically because the cornea is being digested. And remember, the cornea is a proteinaceous based structure, so it's collagen based. And so when we get enzymes, which we'll talk about in a second, when we get those enzymes, the cornea breaks down and it can be a real problem. And so anytime we have stromal involvement, we know that there has been an infection or there is a current active infection. So in this image, we can see that this kind of looks like snot on the surface of the cornea. It kind of looks gross. I mean, it's cool to me, but for the average person, they're like, oh, that's kind of gross. That's how I feel with like skin and teeth. I just find them disgusting personally. I'll take a hole in the eyeball, of course, over gross dental disease. So that's thank goodness there are dentists and dermatologists out there. But as an ophthalmologist, so this is definitely, we can see that there's this kind of melty appearance. And then you can see that there's like a very, very mixed topography, right? It's not like skin peeled off a grape. There's this irregular surface to the cornea, so sort of a peak and a divot, and there's a significant crater right there you can see. And so this is a really classic example of an infected ulcer. And so other forms of infected ulcers, they come in all varieties and shapes, right? So here's an example of a case that we saw recently. Actually had a focal perforation, and this is a little bit of iris saying hello to the outside world. Not so ideal for the dog, but we can see that there's this sort of like, again, this sort of stringy, sort of snot-like appearance to the in and around the cornea, and at the periphery here, there's sort of it's a little bit hard to see, but there's this sort of white creamy area, so this infiltrate, and again, this is just sign of active infection. The blood vessels are starting to come in to try to fight that infection. And it's a response to irritation on the corneal surface. And we actually want those blood vessels to get in there. That's what's going to help to heal this cornea. We can tell those vessels to go away. This middle image, we can see, this is more classic, where we can see this sort of creamy white rim around this depression. So it looks like a crater in the cornea. Well, it is. It's like 30% loss of corneal thickness. And we can see this white creamy area. That's that infiltrate that I'm talking about. That's those white blood cells that are coming in to fight this infection. And then in the center there, it may be hard to see, but it's kind of, again, sort of a melty appearance. And this is a very classic, this is a really bad bacterial infection that came in, and its entire cornea was sort of melty. And then we've got this infiltrate peripherally. And then this area here is actually in the anterior chamber. So it's white blood cells. So this is hypopyon in the anterior chamber. And again, what's happening is there's sentinels inside the eye. It gets leaky. We got a little bit of reflex inflammation. In this case, there was a lot of reflex inflammation, and it's the body responding to that nasty infection and getting ready to prepare for it potentially to perf. Okay. Unfortunately, this dog did not perf, but it's pretty bad infection. So how do we handle this? Let's delve into that right now. So what causes corneal malacia, or AKA melting? Like I mentioned before, we have these enzymes, so proteinases, and specifically collagenases and gelatinases, which are given off by our infectious agents. And we'll go through some other reasons where we get these enzymes. And remember how I mentioned that cornea is proteinaceous, it's collagen based. So when you have enzymes, that's a bad combination with a protein structure. That means that it's going to break down, and that's where we lose our corneal thickness. So we lose that thickest layer of the cornea, remember? So the outer protective epithelium is removed when you have an ulcer, right? And that allows exposure to get those bacteria or infectious agents into the underlying stroma, which is the thickest layer of your cornea. And that's where the collagen is we've got these collagen fibers that are nicely aligned, keeping it nice and clear. And so we have to be mindful of what's happening with these infections. Okay, so the biggest source in our canine population is bacteria, naughty bacteria. So again, we get that outer protective epithelium that gets removed. So it starts out as a superficial or simple ulcer, and that outer protective epithelium is removed, just like when you get a cut on your skin. It's like, you put Neosporin on it as a preventative. It's not an active infection, and that's what we do for simple ulcers. But sometimes we get bacteria in there that's not responsive to those particular antibiotics, and they wreak havoc in the cornea. So again, our gram-positives like staph and strep get in there most commonly, just like our skin, and then our gram-negatives like Pseudomonas get in there. When we get these bacteria that get into the underlying stroma, they love that collagen. It's like a party in the cornea. Literally, it's a petri dish. And so basically, what they're doing is they're like replicating like crazy. I always joke to our students that it's like a college party gone out of control, and the bacteria are the college students, right, wreaking havoc. And then what happens is, because we've got all these bacteria in there, the body's natural response is to send in these neutrophils. And I always refer to the neutrophils like the police, right? They don't do a good job of corralling these out of control bacteria, aka college students. And so the neutrophils have, they try to engulf these bacteria. And what happens is those neutrophils will break open. And guess what? They contain also enzymes. So we have further breakdown of the precious corneal collagen. Okay. And then finally, in our analogy that I like to use for vet students that makes them laugh, is we have our endogenous sources of enzymes. So within the cornea itself, and these are the matrix metalloproteinases, which I'll refer to as MMPs because matrix metalloproteinases, say that 3 times fast, it's a lot. It's a big mouthful. So MMPs, so 2 and 9. And normally they're at imbalance, right? But when we have corneal injuries, that MMP9 increases, and we have an imbalance there. And what happens is you have further breakdown. So I refer to those as the neighbors that are angry at this college party happening. So they're just unhappy with this current situation. So you can see how bacteria, neutrophils, and actual enzymes within the cornea further break down the corneal thickness. And that's where these infections, we are behind the 8 ball when we see them. Okay. So next thing we have to ask ourselves is, what kind of medications can we help to seize this corneal melting? Because when you see a case that comes in like this, you're like, how do I get this under control? This is a melty mess, right? So the best agent we have is Mother Nature. Our serum and plasma contain alpha-2 macroglobulins, alpha-1 antitrypsin, more than you need to know, but they inhibit both the MMPs and serine proteinase and proteinases. And so it gets both trajectories of our enzymatic digestion, right? So really great product. Now, if for some reason you're in practice, and this always happens, right? It's 5 o'clock on a Friday. You have no blood donors. They all went home. You're out of the blood product, the serum or plasma in your practice, and you have a 2-pound angry Chihuahua that comes in that has a horrible melting ulcer. And you're like, what am I going to do? I can't exsanguinate this dog, right? It's angry. You have to muzzle it. You know, we've all been there, right? You're like, gosh darn it. Well, you all have purple top tubes, right? And so you can actually make a 1% EDTA solution out of a purple top. You fill it halfway with eye wash, sterile eye wash, or if you only have saline, you fill it half with saline, and you make a 1% solution. So in a pinch, that can work in practice. So that 2-pound Chihuahua can get started until you can get blood product back in your clinic, whether it's a donor dog or using Repair. So EDTA is a nice anti-melting agent. It's not as effective as serum or plasma, but it can definitely do better than not having any anti-melting agent on board. Also, tetracyclines are another product that can prevent melting of the cornea, and it also inhibits MMPs. So again, we have our products like oxytetracycline, interamycin, so that oxytetracycline polymyxin B can be used to help to prevent melting if we don't have too deep of an ulcer. Obviously, if it's ready to perforate, we don't want to be putting ointments on, because that petroleum in that ointment is irritating to the inside of the eye should that eye perforate or that ulcer perforate. So again, we don't want to be doing it in something where we're questioning whether the stability of that ulcer. And then finally, we have N-acetylcysteine, which is another product that also inhibits MMPs. This product is kind of irritating, so we don't use it on a routine basis, but it is something that if you happen to have it in practice and you don't have any of the other products above, it is something you can use in a pinch as well. So again, our best product is our serum and plasma, which is our blood product, because it gets both enzymatic pathways. Okay. So then what other things are beyond that what are the other pro-wound healing components of serum beyond the anti-melting property? So this is the thing that I love about the blood products, especially serum. We have growth factors, so epidermal growth factors and transforming growth factor beta, which are known to stimulate cell proliferation, migration, and differentiation of corneal cells. So it's helping to try to heal the cells, like getting those cells where they need to be. There are epitheliotrophic properties, which are known to support and promote health and repair of corneal epithelium, which is really important. That's the glue, right? If once we get that ulcer epithelialized, we're healed, we're done. We don't have to worry about this ulcer being a problem anymore. So we want epithelium to march in and heal the defect, right? That's the goal. Then that ulcer is healed. So having an epitheliotropic property is key to healing success. And then the other thing about serum is that there is an anti-inflammatory and antimicrobial substances like immunoglobulins and lysozymes that also are really important and quite fascinating, that are part of the blood product, that really will help the healing process. And we'll go into that in more detail with some of the research. So, all right, moving on. So guess what? We have an infected ulcer. What do you do next? This is the, don't panic. It's like I see the deer in the headlights with the students when sometimes I'm asking them questions. I'm like, take a deep breath. You know more than you think you know, right? So when you first know that you suspect that you have that infected ulcer, some of the images that I showed, you're like, that looks nasty. The first thing you want to do is obtain a culture and sensitivity, okay? Aerobic culture and susceptibility, just like you would if you had an abscess somewhere else or a suspected lesion somewhere else, you'd want to obtain that culture and sensitivity before you put anything in the eye. You don't want to dilute it out, right? And the question is, where do you sample that, right? So if you think about skin, the cornea as modified skin, when you have a derm lesion, right, on a dog, you're going to be, where's the active infection? You have to ask yourself. And the active infection is in a skin lesion is at the periphery, right? The center area is going to have the shmoo, and in real technical terms, it's going to have the debris, sort of dead and devitalized bacteria and cells. The active infection is at the periphery. And when we think about cornea, it's modified skin, okay? So don't make it more challenging than it needs to be. So that same concept of your derm lesion or your skin lesion is going to, is going to be exactly the same for the cornea. So your location of sampling in the cornea is going to be at the periphery of that infection, because the center is going to be this dead, devitalized debris that is really, I like to call it shmoo, because it's just like it's not going to be effective at telling you what's going on with that infection, right? So you want to get that sample at the periphery. And so again, you want to do this before you put anything in the eye, ideally. If the dog's really painful, okay, put some topical anesthetic for Paracane, because we don't want to do more harm than good. So sometimes you have to do that. But in a perfect world, we try to actually sample, get our culture before we put anything in the eye, so we maximize that yield of bacteria, ideally. And then you're going to want to do a corneal cytology. And this is important. Why would I do that? Why am I continuing to torture this dog by getting samples? Well, remember, how long is it going to take for that culture and sensitivity to come back? It's going to take a good 7 to 14 days. We don't have 7 to 14 days to get that result back. We need to know what kind of bugs are growing on the cornea, right? So the cytology is going to provide you information on what kind of bacteria there. Do we have cocci? Do we have rods? Do we have a combination of cocci and rods, or as I like to refer to as a fecal smear on the cornea, from the cornea, when you have so much bacteria per 100 high power field that you're like, ooh, this looks like somebody scraped a toilet seat. This is gross. And so the cytology is going to help to dictate what kind of infection you have and what kind of antibiotics you need to generally select. Because I generally think of cocci as being more gram-positive as a rule of thumb. Rod-like bacteria is going to be more of a gram-negative spectrum. And so if you have a mixed population, you're thinking, I got to have a gram-positive and a gram-negative. And that's a general rule of thumb. There's always exceptions to the rule, but that's a general rule of thumb, okay? So then what am I going to do to sample? And what we use here at Iowa State, and a lot of ophthalmologists love, is these little cyto brushes. They're fantastic. So they're great because they're delicate, they're really fine, and you can get in there and not cause a lot of trauma to the cornea because they're very soft, but they exfoliate these cells very well onto a slide. And so that's why we really like these cyto brushes, because they're really very minimal trauma, but we get a great cytology and sample. And then if you don't have cyto brushes, you can always use the blunt end of a scalpel blade. As you see here, please don't use the sharp part. That's common sense, right? You don't want to put pokey things near the eyeball. But the blunt end works really well in a pinch if you don't have other sampling techniques. I don't recommend cotton tip applicators, because cotton tip applicators don't exfoliate those cells off easily. They just sort of stick to the cotton tip applicator. So you're not going to get a good cellular yield. And then there's the chimera spatula, which in some practices may have. You just want to make sure you disinfect that in between times. So again, I highly recommend the Cyto brushes. I'm a little biased, but I do think that they are worthwhile investment in your practice because it's going to make your cytologic sampling fruitful, and you're going to have good outcomes as far as, knowing what you seeing what you have on the cornea. Sometimes even when you do cytology, you don't see active bacteria, but you see neutrophils. If you do see neutrophils, they should never be on the corneal surface. So that just tells me that there is active infection going on. That's the infiltrate that we're seeing. Sometimes, again, you just don't get that bacterial yield. But when I see neutrophils, I say, okay, it is infected. I need to take action. Okay. So even if you don't see active bacteria, okay, hopefully that makes sense. So next, you have to ask yourself, how do we treat these infected corneal ulcers? Okay, so I'm going to be using a broad spectrum antibiotic, but I'm going to base it on my corneal cytology. That's kind of my investigation as best as I can, because again, that culture and sensitivity is not going to come back for at least minimally a week. If we get preliminary, we get lucky. I always say we get preliminary data of our culture in about 3 to 4 days. But in the real world, when I worked in private practice, it was usually about a week. So realistically, cytology is what we're basing it on. We are also going to start a blood product, right? So we want, again, that antibiotic is going to help to slow this infection down and try to resolve it, right? The blood product is there to help prevent that breakdown of the cornea, because again, we have only 500 to 600 microns of cornea, which is like 0.5 millimeters, right? Half a millimeter. It's not that thick. So we have to be aggressive about getting this infection under control. Atropine is what we use for direct pain control inside of the eye. And what it does is helps to stabilize the leaky blood aqueous barrier. So when we have an active infection within the cornea, we're going to have inflammation or reflex uveitis inside the eye. So we get this inflammation because the same innervation within the cornea innervates in the inside of the eye. So when the cornea gets pissed off and has an ulcer, right, those nerve endings are exposed, because that's just underneath the epithelium and it's within the anterior stroma. And basically those same nerves stimulate the inside of the eye. So we get this active inflammation. And so in order to help, prevent that Charlie horse from happening or reduce that Charlie horse within the eye, which is what's happening with those muscle spasms, with the ciliary body muscle spasming and the sphincter muscle, iris sphincter muscle spasming, we're going to relax that. That's a direct relaxation. And so it's a direct pain control. So we're basically saying, hey, stop spasming. The other side effect, the side effect is pupil dilation. But the other thing that does is it actually stabilizes the blood aqueous barrier, which is that leakiness within those vessels. It helps to stabilize that. So not only is it direct pain control, prevents adhesions like posterior synechia or adhesions between the iris leaflet and the lens, but also it stabilizes that leakiness within the eye. So we help to reduce the inflammation inside the eye. The other thing that we always want to do when we have an active infection is we know, like I mentioned before, we have active inflammation. What you never want to do with any ulcer is put topical steroids, right? That's the circle / don't do it. I'll feel it in the ophthalmic force. It'll make me cry. You don't want to make me cry. But you still even don't want to do a topical like an NSAID either, because topical NSAIDs can actually reduce or delay the wound healing. It's like they're a bit epithelial toxic, and it can delay wound healing. So we don't want to do that either. But what we can do is systemically do oral NSAIDs. So oral NSAIDs like carprofen really do help our intraocular inflammation, and it also helps pain control as well. The other thing that we also use all the time, probably we can kind of give it out like candy, I hate to admit this, but gabapentin, okay? So gabapentin is great for neuropathic pain, and that's all ocular pain is neuropathic. So we like, I'm not joking, we hand it out a lot because a lot of our patients, we're improved on systemic NSAIDs, but we can't keep them on NSAIDs for weeks on end, right? So eventually we do it initially to get the inflammation improved inside the eye, but then we'll kind of eventually transition, keep them on the oral gabapentin long term because that's a little bit safer. So gabapentin is great for eye pain. Okay, so we use that. You might see that I have plus or minus oral antibiotics. We will use that if we have active corneal vessels getting into the infected area. So if I have active vessels in the site of infection, I'm going to use you can always use an oral antibiotic. Or the other reason I might use an oral antibiotic if I have an infected corneal ulcer that's very deep and I'm worried it's going to perforate, or it actually has perforated, absolutely, that's when you want to use an oral antibiotic like broad spectrum. So oftentimes we'll use Clavamox. If I am using it for for the anti-melting component, I'll use an oral doxycycline. But if I'm worried about it perforating or it's a nasty infection with broads and cocci, I'll use Clavamox on a routine basis. Okay, so going through that, so let's talk about more details about what we're going to do. How frequent are we going to use these medications? So serum and broad spectrum antibiotics, I'm going to want to initially initiate a every 1 to 2 hour regimen, and I'm not doing it to torture the owner or torture the dog. Remember, we're behind this infection, so it's been going on longer. Even if it's hours longer, and it's wreaking havoc in the cornea, or days, we're behind, right? So we have to catch up. And the reason why we're doing that is we're trying to catch up and get the infection under control and stabilize that corneal melting. The atropine, oftentimes we'll do that 1 to 2 times a day, depending on the severity of the reflex inflammation. You always want to make sure that there's not active glaucoma going on, or secondary glaucoma or high intraocular pressure. Also, you want to be cautious if you have this patient has underlying dry eye, because remember, atropine can transiently decrease tear production. So oftentimes if we have a dry eye case, we might do a drop of atropine, but not send the atropine home, okay, with the client, because I don't want to persistently make that dry eye worse. Again, oral NSAIDs, usually we'll do that for week to 10 days, up to 2 weeks if it's really bad inflammation and we need to control it and the body system's okay for that. Obviously, we would do blood work before we start ramping up and doing NSAIDs orally. Gabapentin, we throw at them every 8 to 12 hours as needed for pain control. And we're going to be rechecking these guys in 24 to 48 hours. So this is going to be, and the reason why we're doing that is, again, I've empirically selected topical antibiotics. I want to make sure that we're not getting worse on those antibiotics, right? So that's why we're wanting making sure that that infected ulcer is stabilizing, not getting worse. Okay, so that's why 24 to 48 hours, you want to recheck these. Now, if I have an ulcer that's like this, where it's, a deep stromal ulcer, so there's still stain uptake, so it's not a desmetaseal, or in this case, it is a desmetaseal. It's like, 1 cell layer thick. If it's greater than 50% stromal loss, the gold standard is to recommend some sort of tectonic support, like a conjunctival flap placement, where you basically harvest that bulbar conjunctiva from the periphery, rotate it down, suture into the base or into the weak spot within the cornea. And guess what? It's providing tectonic support and direct blood supply, aka serum, to the defect. And allowing things to heal and preventing rupture and stabilizing to the point where we can hopefully preserve vision. And this is what the conjunctival flap looks like. This, surprise, surprise, is a Brachycephalic, a Boston Terrier. Never happens to them. And here's that pink tongue, I like to call it, which is the conjunctival flap that gets sutured into the cornea and becomes one with the cornea, and eventually will contract down and actually look pretty decent long term. And so that's kind of a little bit about, infected ulcers. So what I'm going to move on to is the next kind of question. Oh, did it stop? Hello? There we go. I had a pause there. So when we have infectious keratitis or bacterial keratitis, we have concurrent conjunctival hyperemia. And so why am I worried about conjunctivitis? Why am I asking that? Well, we know from previous studies that there's an increased concentration in dogs when they have conjunctivitis versus healthy eyes. It was a cool little study done by a colleague of mine, actually when he was at Iowa State here before me. And you can see in the middle B that the tear albumin concentration is basically 17, almost 18 milligrams per mil compared to the normal eye at 1.7 milligrams per mil. So there's an increase or uptick in albumin concentration. Okay, so why do I care about that? So when we have infectious keratitis, there's a breakdown in the blood-tear barrier. okay? And so here's an example of our healthy eye where we have normal tight junctions within our epithelium. And when we get this conjunctivitis, those conjunctival blood vessels release these more albumin molecules into the tear film. And so this is the next question. Why do I care about albumin getting into the tear film? Why does that matter? So why does an increased albumin concentration matter? Well, we know from previous studies that albumin decreases antimicrobial efficacy. Also studies have shown that albumin decreases drug bioavailability of topically administered medications, and albumin can also affect drug diffusion of systemically administered medications. And so, okay, the next thing is we use serum and plasma, most commonly dogs and horses in clinical settings, and numerous studies have shown that this is safe and effective at reducing collagenal lysis. So let's go back to, well, serum and plasma, they contain high protein levels. And so could these protein levels impact our antimicrobial efficacy? Well, we know that albumin can bind to free antibiotic. And so only the unbound fraction of antibiotic is microbiologically active. So that kind of, all this sort of deep research, previous research kind of made us think, gosh, what is the level of albumin in our blood products? And so that led us to our first study, which we wanted to actually evaluate fresh and frozen canine and equine serum or plasma. And the first objective was to determine the albumin concentration from each of these species. And does it matter whether it's fresh versus frozen sampling impacting these levels of albumin? And a secondary objective was like, hey, let's determine the impact of albumin in this plasma or serum on samples on the antimicrobial minimum inhibitory concentration for common bacterial pathogens. So what we did was we took 10 healthy dogs and 10 healthy horses. We obtained blood samples. So our serum was placed into red top tubes, plasma into green top. We centrifuged them down, sterilely removed the liquid components. And then our fresh samples were processed within 24 hours. Our frozen samples were stored for about a month at -20. And we wanted to do this to mimic clinic scenarios because that's how most people store their frozen blood products. And then to assess for albumin concentrations, we used a species-specific ELISA kit. We did processed and obtained, created standard curves, and each sample was run in duplicate. We also wanted to look at, to assess MIC, we used control plates, and we ran our frozen plasma, frozen serum, and fresh plasma and fresh serum in duplicate. So here's an example. We had the 10 dogs, and we, in the plates, the wells, what we placed is 25 microliters of the blood product with 25 microliters of the bacteria. And our positive control is just bacteria, okay, 25 microliters. And so we wanted to see, hey, does the bacteria still grow? All right, in those two columns, the positive controls. And then what happens when we plate it just with blood product? And none of these wells contain any antibiotics. So that's the important thing to emphasize. Okay. And then to further assess MICs, we used JOI2 plates, which contain 17 different ophthalmic antibiotics. And we wanted to sort of determine how do these blood products affect the MIC, or do they at all? And so how do we further do that? Well, we use 30 canine infectious keratitis bacterial isolates from our clinical patients. So we had 10 Staphylococcus pseudointermedius isolates, we had 10 Streptococcus canis isolates, and 10 Pseudomonas aeruginosus isolates. And we had 8 test groups. So we had our canine fresh serum and plasma, we had our canine frozen serum and plasma, our equine fresh serum and plasma, and our equine frozen serum and plasma. So what were the results? So when we looked at our albumin concentration, what we found was that our equine, whether it was fresh or frozen blood products, ranged from about 25 to 26 milligrams per deciliter, and our canine albumin concentration ranged around 14 milligrams per deciliter. So definitely there was a fair amount of albumin present. Okay, so then the next thing we were like, well, so what happens when we just plated them? Look at our control plates. So this was the most fascinating part, which in our equine control plates, we looked at the percentage of bacterial inhibition, And interestingly enough, when we look at our fresh serum and frozen serum, we found that there was up to 97.5% inhibition for Staphylococcus species. And again, there was no antibiotics placed in these wells. So this is all just blood products. So that was super fascinating. Strep, there was no inhibition, but Pseudomonas, we had about 34 to 46% inhibition when plated with our fresh or frozen plasma or serum equine specific. Then when we looked at the canine control plates, there's only about 15% inhibition within our Pseudomonas population for the fresh plasma and fresh serum. The rest did not have any antimicrobial activity or inhibition. So then what we do with what happened, what's the serum and plasma, what were the serum and plasma MIC effects? So when we looked at canine and plasma and serum compared to control, there was an increased MIC of selected antibiotics up to 1.5 to 10.8 fold. And when we looked at equine plasma and serum compared to our control, there was an increase in the MIC of selected antibiotics about 1.5 to 5.4 fold. And then in some cases, there was also a decreased minimum inhibitory concentration of selected antibiotics around 2.25 to 0.67 fold. And so what we realized was it really depended on the antibiotic and the bacterial isolates where the MIC was affected. But it did have some effect on the MIC. When we compared the MIC fold difference, however, there was a statistically significant decrease in the MIC effect on the MIC in the equine blood products. So it was 1.9 micrograms per mil compared to 2.9 micrograms per mil in the canine blood products. So again, that was quite fascinating. So what does this all matter? So conclusions and clinical relevance, that's the most important thing, right? I'm jabbering on about MICs. What does it mean? So our serum and plasma both can reduce antibiotic efficacy due to the antibiotic protein binding, so that high levels of albumin. But the other components are super important to promote wound healing. So how do we manage that? Well, we apply our blood products last, and we space the administration from the topical antibiotics at least 10 minutes, because that will allow for proper absorption of the topical antibiotics, maximizing its ability to fight off the infection. And then we're putting on our blood products, which are going to be the anti-melting, pro-wound healing, good juju, which is totally not technical, but that's what I call it, good juju for the cornea, okay? And based off our study, this particular study, the equine serum and plasma seemed to be better than the canine serum and plasma, as there was greater antimicrobial effects due to less impact on the MIC. So again, interesting results for the equine. Somebody joked to me, well, horses can do something, right? Because oftentimes they'll colic and do all kinds of crazy things, but their blood is actually quite effective at and impactful and good healing. So that was the first project. The next one is we're like, what about cows? What about those bovine that heal their corneas so well? What is it about their blood products? So the second study, what we looked at is the same sort of setup. We wanted to look at fresh and frozen bovine serum and plasma, and we wanted to determine the albumin concentration in bovine blood products. And this next question was, does fresh versus frozen sample impact the albumin levels? And then we wanted to also determine the alpha-2 macroglobulin concentration, because that had been looked at in equine and canine, but never in bovine. So we're like, hey, we should look into that. And then we also want to determine the impact of albumin in plasma or serum samples on antimicrobial MIC for common bacterial pathogens. So surprise, surprise, we sort of did the same thing. We took 10 healthy cows as our study population. We obtained blood samples, so our serum and plasma, processed the fresh samples within 24 hours, frozen samples stored for a month, -20, again, to mimic clinical scenarios. We did our albumin concentrations determined with a species-specific ELISA kit. Again, created standard curves and we ran each sample in duplicate. And then in order to determine the alpha-2 macroglobulin concentrations, again, we used a species-specific ELISA kit, created standard curves, and ran each sample in duplicate to obtain those levels for our frozen serum and plasma. And then we did the same thing. We wanted to do control plates to assess the effect of the blood product on our microbes, our bacteria. So we plated the blood product, 25 microliters with 25 microliters of the bacterial isolates. Again, our positive control was just our 25 microliters of just bacterial broth. And then no antibiotics were plated within these control plates. Okay, so they were just the blood products against the bacteria. Okay, and then we did the same thing with our MIC assessment for using the JOI 2 plates, that the 17 different ophthalmic antibiotics, to see what those affect, how did it affect the MIC. Again, used our 30 canine infectious keratitis bacterial isolates. Again, we wanted to see how that would affect. So our 10 staph, our 10 strep, our 10 pseudomonas. Okay, and then we had our 4 test groups. So we had bovine fresh serum and plasma and bovine frozen serum and plasma. So when we came to the results of the albumin concentration, this was surprisingly low. I did actually ask the lab to triple and quadruple check it, because I was like, really, this seems awful low. So what we were getting was 1.9 to 2.2 milligrams per deciliter. And you remember canine had about 13 or about around 14 milligrams per deciliter albumin concentration, and equines had about 26 milligrams per deciliter. So we're relatively low. And then when we looked at our alpha-2 macroglobulin concentration, oh, what happened to my hair? Hello. Technical glitch here. I think PowerPoint just decided to, one moment, hold on. It decided to, sorry about that. And we'll get back into, all right. All right, can you still see my slide here, hopefully?
Yes.
Okay, thanks. Sorry about that. I don't know what happened. PowerPoint had a short out there. So when we looked at our alpha-2 macroglobulin concentrations, what we could see is that with our frozen bovine serum, we had around, what was it, about 44,400 nanograms per mil, and our frozen bovine plasma was about 5,000 nanogram per mil. Compared to previous studies looking at canine frozen serum, that was about 98.7 nanograms per mil, and then equine serum was up to about 500,000 or 550,000 nanograms per mil. So bovine serum and plasma were right sort of in the middle, decent macroglobulin concentration. So that's good. I mean, I'm happy with that. When we looked at the bovine control plates and the percentage of bacterial inhibition, we did find that there was a significant inhibition of staphylococcus, about 25 to 49%, and then with Pseudomonas 7 to 32%. So there was some antimicrobial effects. Again, these were plated without any antibiotics. So again, we're seeing some inhibition just with the blood product in and of itself, which is pretty exciting. And then when we looked at bovine plasma or serum compared to the control, we had evidence of increased MIC of selected antibiotics from about 1.1 to 3.3 fold. And there was a decrease in the MIC of selected antibiotics about 0.4 to 0.95 fold. So again, it's really dependent on the antibiotic and the bacterial isolate, whether there was increase or decrease of MIC, but it was a lot less than the other blood products. What does that mean with the median fold difference? Let's look at that. So our median fold change in MIC compared to control was about 1.1 micrograms per mil. And compared to the horse, the median fold difference was about 2 micrograms per mil. So again, even lower effect on the MIC with our bovine blood products, that was also quite exciting. So what does this mean clinically? What is the conclusion? Well, bovine serum and plasma appear to be in some ways greater than the equine or canine serum plasma, as there's greater antimicrobial effects due to less impact on the MIC. Both equine and bovine both have antimicrobial components to them. And, if you look at the alpha-2 concentration, equine might be superior there, but bovine also has a fairly high alpha-2 macroglobulin concentration. And so what's the next step? Okay, so that comes to serorepair, right? So this is enhanced bovine serum, and it's commercially available. So next thing that we want to do is investigate the antimicrobial effect of this enhanced bovine serum, and to investigate the effect on MIC of common topical antibiotics. So that's something that we're going to be looking into as collaboration to sort of say, hey, is this enhanced bovine blood product going to be even better than the natural occurring stuff? So that's, so that's something that we're going to be working on in the near future here. So stay tuned for that. Exciting research. So next thing we want to go is, in conclusion, what do we take away from this? Well, we know that serum is excellent for stabilizing corneal malacia or melting, so anti-collagenalytic, so it prevents that cornea from breaking down. We know that we have, it has pro-wound healing growth factors. So it's like, I always joke to my my residents always joke that I love the blood products a little bit too much. But I'm like, it's good juju for the cornea. It's got good pro-wound healing components. So those growth factors that help to migrate and proliferate the necessary cells to get where they need to go. And we know that there's antimicrobial effects based on our previous research. And again, proof is in the pudding. So not only is it going to help prevent melting, it's going to be promoting the healing process, and it also can help, prevent, or reduce that microbial growth, okay, depending on what you're dealing with. The other thing that we need to emphasize is, because that serum and plasma contain the albumin, it's going to be important to administer the blood product at least 10 minutes after instilling that topical antibiotic to prevent that albumin binding, to maximize our antimicrobial effect. And so that's something that these studies have shown to help to promote and maximize our ability to fight that infectious keratitis, that bacterial keratitis, and maximize the healing of these infections, and hopefully minimize fibrosis down the road. So again, super cool stuff. This is the research that I love because it's actually clinically relevant, and this helps our patients to improve and hopefully saving some eyeballs. Although my bad joke that I tell the residents and students is, we never lose an eyeball. It's always saved in formalin. So it's bad. It's a really bad joke. Anyway, so my references for those of you that are interested. And at this point, I think I'm happy to entertain questions. And this is one of our wonderful research beagles that was so kind to give up his blood for future dogs' corneas.
Thank you, Dr. Kubaiwill. Yes, we're opening it up to question and answers. I do see a couple of questions that we have out here. There's a question on, do we ever do third eye flaps anymore?
Okay. So do we ever do third eyelid flaps? Not like, I don't recommend them routinely. So the reason is, I'm nosy. I want to see what's going on with the cornea. When you put the third eyelid flap, it basically, you can kind of go away and be like, I'm going to forget about the cornea. But I, as an ophthalmologist, they're one of the things that I don't love, because I can't see what's going on in the cornea. Is it getting worse? Is it not? The only times I'll place third eyelid flaps is with cats when they have bullous keratopathy, or you have a patient that can't undergo, say, a conj flap surgery, and you want to do some sort of tamponade to the weakened cornea. Yeah, at that point you could do a third eyelid flap or a temporary tarsorrhaphy to sort of act as a tamponade to the weakened cornea. But generally, I'm not a big fan of third eyelid flaps.
All right.
That was a good question.
Yep. So I have another question. If you guys have any questions, go ahead and type it in the Q&A, and I'll go ahead and speak it out and send it. I have one more question. It says, how different is success rate with the indolent ulcers versus infected ulcers? Infected ulcers, sorry.
So with blood products, is that?
I'm assuming so, yes.
So the studies out there on indolent ulcers and blood products are not, so let's put it this way. The studies did not show significantly a significant improvement in healing times when they used blood products like serum on an indolent ulcer. And so that's okay, statistical significant increase in wound healing compared to not using it. I personally think it's not going to hurt, even if it may not necessarily speed up wound healing. I think there are good components that can help to promote healing of these indolent ulcers because they can be challenging to heal. So I'm not against doing a blood product for an indolent ulcer. Infected ulcers, there's no question I'm going to use a blood product for those. And I think absolutely they're going to help to speed up healing because you're going to, protect the integrity of the cornea and promote good wound healing processes. So, but the indolent ulcer, even though technically the studies have shown that it doesn't significantly increase wound healing, I do think that it helps to promote healing in general, but not necessarily speed it up.
And what is your source for atropine?
So atropine, I know I know our technicians order it. I don't know exactly where they get it from. I know that's been a bit of a challenge to get it from outside from pharmacies. There's been some back order issues, especially atropine ointment. I think we might get it through McKesson's. I'd have to ask my technicians. So I'm not sure exactly the source, but I wish I did. But they're so amazing that they do most of that stuff for us.
All right. Given that we want to apply the serum last, I'm assuming that you would never use an antibiotic ointment? Question mark.
So not necessarily. So with an antibiotic ointment, you're just going to wait longer to administer. So I might wait 20 minutes, or 15 to 20, just allow for that lubricant to kind of become more liquefied. So yeah, so you just have to wait a little bit longer to instill that blood product, because you're not going to be able to, if you instilled it right away, it's going to be too, the petroleum based component there'll be no point to instill it.
And Brad was talking about solutions only. So when you asked that question.
Mm-hmm.
And then Karen asks, can we use this product in cats?
Oh, yeah. Oh, absolutely. So the beauty of the blood products is there's no antigenic component. So the cells are all removed. And so honestly, I've used canine blood on cats. I've used equine blood on cats. I haven't used bovine blood on cats, but I wouldn't have any hesitancy to do so. So, and again, with cats, good luck getting a decent enough blood supply, blood sample on a angry cat that has a painful eye. So I always use another species blood product, plasma or serum on a cat. Yeah, all the time.
And we just did that here at IBS too. So just yesterday.
Yep, and it works great.
Yeah. Can we collect blood from other patients can we collect blood from the patient with the ulcer and spin it down for that serum?
You absolutely can. The biggest thing is if the dog has a weakened cornea, you might not want to, especially the jugular. So just be mindful there. But absolutely, you can get the same blood from the patient. Absolutely, that's not a problem. Just be mindful of if it is a weak cornea, you might not want to.
Your topical choices for antibiotics for infected ulcers prior to CNS results.
Yeah, so again, it depends on say the cytology, but my preferred, like if I see a bunch of cocci, my preferred gram-positive antibiotics topically would be cefazolin, and usually that's compounded like a 5% cefazolin, chloramphenicol for gram-positives, neomycin, so neopolygram. So those would be the gramicidin component. for gram, like rod or gram negative, I'm looking at ciprofloxacin, ofloxacin, tobramycin, gentamicin are my kind of go-tos. So bigger guns is what we're going for, not our first line like triple antibiotic or terramycin.
Okay, there's a question that says use of HA repair gels and healing.
Yeah, so the HA repair gels are something I would use as an adjunctive lubricant. I feel like they're not going to hurt, but when I am doing treating for infectious keratitis, I'm wanting to make sure that I get my antibiotic in, my blood product. If the owner can get an HA product in as a lubricant, I'm supportive of that, but I wouldn't just use that in place of blood product.
Expanding on the cat question, what species can donor eye serum be used on?
I've used it in pretty much exotics. I've used it in any species. So I basically I'm not afraid to use it in, like, you know, say even a reptile that has an infected ulcer, or a bird, canine serum or equine serum. Again, it's not it's the liquid component, so you're not going to have an antigenic reaction. So you can use it in any species, which is cool. This is what I love about it.
Yeah, so the serum, there was a question on the serum. Can this be only used in the cases where the ulcer is melting, or is there something to be part of the initial therapy when first presented with the uncomplicated or superficial ulcer?
That's a good question. I generally don't pull out blood products for like a simple ulcer, just because most of them are going to heal within 3 to 5 days without complication. But if they come back in 3 to 5 days and they look like they're starting to get infected, absolutely, that's when I pull out the blood products. But I generally don't do it with simple ulcers, just because I know they're going to heal within 7 days without just with prophylactic antibiotics and pain medication.
For equine serum, is the EDTA plasma better than serum form of the red top in terms of less clotting?
That's a good question. I'm not against the clotting. You just have to, especially with equine serum, as you probably know, it's really, you have to sort of spin it around to break up that clot and respin it multiple times. So, and to get the maximum serum out of it. So I do like the red top. It just, you have to work at it a little bit to maximize the yield of the serum that you get off of it. But I like serum. I called it liquid gold in private practice. It was incredible, because I used canine blood products for years. And then I switched to equine because I was like tired of trying to be like, hey, coworker, can you bring your big dog in? We're almost out of blood. Hey, coworker, can you bring your another big dog in? We're almost out of blood. And then I was like, hey, wait a second. I got somebody who has a horse. I could get like 3 months worth of blood product, out of one horse. And it was incredible. And I started using it and I was like, wow, this is like, my melting is not nearly as bad. And now the research shows why. I have a reason. And that's why I looked into it. Cause I'm like, God, this stuff is like liquid gold. It's amazing. So there you go. Yeah, definitely. Equine blood products are good stuff.
Last question here. It says, is there a benefit in using blood products in cats with viral keratitis, question mark, and then viral conjunctivitis?
That is a good question. I haven't personally used blood products in cats with viral keratitis. I've used it with infection, but I haven't actually used it like bacterial keratitis, like when they get a secondary bacterial infection, but I actually haven't used it for viral keratitis. So that's a curious thing. Maybe I should try that. Maybe they would heal better. I don't know. I've never tried it. Good question. I don't know. We should try it.
There's actually one more question I saw. Sorry about that.
Yeah.
What is the most common reason we should be thinking of when a superficial ulcer is not healing on a recheck week after initial presentation?
Mm-hmm. Yeah. So the question is age, right? So like If it's a young dog, like less than 4 years of age, we have to think about what else is delaying that wound healing. So that's what I consider a non-healing ulcer. So is there a hair? Is there a foreign object? Is there entropion? Is there dry eye? Is there exposure issues? Is there dystichia? So is there something that's delaying the wound healing, right? In a young dog. If it's a middle-aged older dog and it's beyond that 7 days, then you have to think about indolent ulcers, right? So those are the ulcers that don't heal within 7 days in a 7-year-old, 8-year-old Labrador. They look like skin peeled off a grape, but when you put that fluorescein stain on, it wicks underneath that epithelium, because remember, with these indolent ulcers, there's an adhesion problem. The outer epithelium doesn't stick down to the stroma because there's a basement membrane defect. And so basically those need to be treated differently, right? They need to be treated with a diamond burr, a cotton tip debridement minimally, or a grid keratotomy, because they're not going to heal in normal time frame. So 2 different scenarios. Or if there's an active infection, right? And that would look very different than skin peeled off a grape. Okay, there's going to be infiltrate, there's going to be much more inflammation, there's going to be melting. That's going to be a very different scenario. Okay.
All right. Well, thank you, Dr. Kubay and Iowa State University and Serial Repair for making this event possible. If you'd like to know more about upcoming CE opportunities that we host at Iowa Veterinary Specialties, please visit our website at ibsdsm.com.
All right. Thank you. It's been fun.
All right, thanks, everyone.
Thank you. Bye.